we set all this up. When it comes down to the AV needs of this company, Dr. Burrows and myself went to school for about 8 years learning how to use iMovie. We can use the snapshot on our phone to take pictures. We do a pretty good job.
Yeah, and the clicker. Set that down. So if you're hearing us, we've done a good job of turning that on. I've done a good job of walking into the room. Smarter people in our team did a good job of setting it up.
So here's the cool part about today is that when we're asked frequently when we're on the road and also through email and phone call, how does a chiropractor succeed? And a lot of times it's the it factor. The it factor is looking at, does this person have confidence when they're treating somebody, when they're diagnosing somebody, when they're talking to somebody? And then also, are they enthusiastic about what they're doing? And while I can't change your personality, I've tried for many years with Dr. Burlesman, we can help with confidence. And it's not a, hey, I learned about carpal tunnel syndrome, I'm good to go. It's an evolution. And this evolution is fun. And it's fun because what gets one person better doesn't necessarily get the next person better. So you have to know all facets of this disease, also with what else could be causing this problem. And that's where it gets fun. It's recognizing patterns, it's stringing together these memories of this patient versus this patient versus this patient to help patient number 4. So hopefully we're gonna help patient number 5 with this.
Yeah, and that's what we're sharing is that strung together collection that we've gone through the literature to mine out the best practice data. We ran it through a bunch of smart people, the advisory team, to talk about what are the most sensitive and specific orthopedic tests. But most importantly, we came to you, the providers in the field who work in the trenches and understand what works and what doesn't. You see it on a daily basis. So this is a collection of your information and best practices as to how do we manage one of these common problems, the single most common peripheral neuropathy, carpal tunnel syndrome, that everybody's familiar with the carpal tunnel, what it looks like. We're also familiar with how common this problem is, that it affects a ton of the population, 3 to 5% of the population, and maybe a little bit more commonly in the dominant hand. Not surprisingly, when we talk about the etiology, it are those things that cause you to grip all the time. So there's intrinsic risk factors, there's extrinsic risk factors. What do we need to know about what to look at?
That's the tough part is that when we look at the pathology, we look at the diagnosis, we look at that as a point in time that we move forward with the funnel of everything that we know how to do based on all the letters behind our name. But a lot of times we need to look backwards. What are the things that cause this problem to begin with? Intrinsic risk factors is a lot of times blood flow. It's the ability to heal. So people do damage to their body on a daily basis. Look at us as chiropractors. I do damage to my body daily. If I didn't get enough sleep, if I didn't take care of my body, if I did not have diabetes, unfortunately, I'm not going to heal by the next day. And when we need that tissue to help heal that damaged structure, whether it's a muscle, whether it's a ligament, whether it's a nerve, some things are limiting our ability to heal. So we need to address all those different things when it comes to treatment. Some things are easily modifiable. Metabolic diseases, those are a little more difficult and may fall a little bit out of your lane depending on your knowledge and your expertise. However, there is one thing that fits into our lane very well, and fortunately, when it comes to carpal tunnel syndrome, is one of the main reasons they're coming in to see us. They have a symptom, normally it's pain, numbness, tingling, but they've done something to themselves. And it's up to us to figure out what they did to themselves, like prolonged wrist flexion extension. What we find is that there's a lot of things that we can do to ourselves repetitively or posturally to cause our own problems. Some things are with maybe in or out of our control, like pregnancy. But like with pregnancy, is your blood volume, I think it's doubles as far as when you're pregnant. You have a lot more fluid in your body. Well, when you have 9 tendons and 1 nerve in a small space, unfortunately, something is going to pay the price, in this case being the nerve. This was a really interesting study that I found in Work. It was the name of the journal. I think it was in June or July of this year.
You read a journal called Work?
Yeah. That's what I'm
hypocritical.
Well, no, listen, the irony of this one is that actually your texting performance decreases with carpal tunnel syndrome. And while, yeah, I buy that, it's kind of interesting because whenever we don't want to work and we're at work, then we normally text.
Some irony there. I love the one study that you had brought up about, that was 75,000 people that said people who have a history of coronary artery disease have a much higher likelihood of having carpal tunnel syndrome in the future. And
everything.
Yeah, exactly. That it doesn't matter if we're talking about a tendinopathy or if we're talking about a neuropathy. Those are vascular issues. And one of the things that chiropractors are really good at are mechanical issues. We know that biomechanics of what happens when somebody has a forward head, forward shoulder posture, hyperpronation. But two of the things that we don't often think about are, number one, the biopsychosocial aspects. Will that patient choose to get better? And number two, the vascular aspects. So this was one study that reinforced vascular things matter when it comes to neuropathies, peripheral neuropathies in particular. When somebody does have one of those vascular issues, they're going to develop symptoms. And one of the biggest symptoms is numbness and tingling in the distribution of the median nerve. We know that paresthesias in the first 3.5 digits is 77% sensitive for a diagnosis of carpal tunnel syndrome, which tells us something else. That means that about 1/4 of those people who have numbness and tingling don't have carpal tunnel syndrome. We'll talk about that in the differential as well. There's a couple of tests that we'll use, Phelan and Hoffman or Tinel sign. We'll go through those real briefly because you're probably familiar with them, but we'll talk about more so the differential considerations and what are the tests that we use for those things. One of the things that we use to organize those thoughts is we're completely electronic now next door at our office, which means we have a little more paper than usual. But one of the things that we help to structure those thought processes are the exam forms. And so this is a Chiro-Up exam form for their hand and wrist. We're happy to share that with you. We'll send it along with the follow-up information. And it organizes those thoughts that if you come out of a consultation, you go through the OBPQRST, you pretty much already know what are the top 1 or 2 or 3 considerations for this patient who has numbness or tingling. If you don't have that consideration, the exam form's organized in a way that it can help structure that diagnosis. That if you see a bunch of plus signs by the carpal tunnel diagnosis, there we have a likely scenario. If it's more by the pronator teres diagnosis, then that leads us in that direction. So if we suspect carpal tunnel syndrome, what do we do?
Well, to rule in carpal tunnel syndrome is fairly simple, and especially when you have tests like this, the manual carpal compression test. It's one of those fun tests like Tinel signs where you tap on it and it reproduces their symptoms, or what I used to call it in schools a doorbell sign. So in this test, we're just going to create some compression and see if we can reproduce symptoms. We're going to do the same thing with the rest of the orthopedic test. Now, keep in mind that when you're working with the nerve, it doesn't just turn on and turn off. It's kind of like looking for neurologic weakness. You don't do one toe raise or heel raise, you do a couple of them, or a heel walk to look for weakness that may develop over time, because nerves have a little bit of capacity in there to work even though they have some compression or stretch. If we want to add compression to this area, we're going to use Phelan's test. And now keep in mind, a couple seconds, 10 to 15 seconds might be enough to recreate symptoms. And also remember, you're looking for reproduction of that patient's chief complaint. With Phelan's, you look for compression. With reverse Phelan's, we're looking for actual stretch of that area. And when we get stretch of the area, we're also looking for numbness and tingling.
So these 3 tests are a great example of all the orthopedic tests that I imagine many years ago there was a caveman who was the local doctor, and he poked on people and he stretched people and he made things work, and he was the doctor, and the other caveman realized that this person's making more money than the rest of us, so we can be doctors too. We can poke on things, we can hit it with a stick. And so the caveman decided, you know what, I need to come up with some really fancy names for all of these tests so that people can't copy me. So he came up with things like Phelan's and reverse Phelan's and all the tests that you had to memorize for the board, when in reality, almost every orthopedic test has 1 or 3 components. Either poke on it, stretch it, or make it work. And that's the case here, that we do manual carpal compression, or we do Phelan's or reverse Phelan's to compress it or stretch it. And if it fails those 3 tests, or if it doesn't meet one of those 3 tests, then we might not have the diagnosis. But we can simplify those tests, forget about some of the names, and remember, compress it, stretch it, or make it work. One thing that falls outside of that scope is this one, the square wrist sign. This is one of Dr. Steele's favorite tests. I see it in all of his notes. And it's not something that I think any of us are going to take out a goniometer to say, does the thickness versus the width exceeds 0.07. But when it does, we know that that patient's more likely. And tell me if you look at this wrist here, or the wrist that we just had up, one of us should use this at the same time, that if we look at this wrist here, you say, that's a highly likely carpal tunnel patient. This is somebody who has just a chunky wrist, plus they have some compression on the outside of it.
And what we know is that those kind of people are going to have a functional reason behind that to create that structural. And sometimes it's genetic, but we have a lot of people who, like a Dowager hump, when they keep their head like this, your body starts to morph into that position. If you keep your wrists up like this, you will have some greater wrist width in that area. Tinel sign, this is one of those, if one, like Dr. Brolin said, if you tap on it and reproduce symptoms, if you have a nerve that's a little hypersensitive, a little inflamed, and you go and irritate it with a hammer, you'll see some reproduction of symptoms. I would say though that by far my favorite test is this one. It's the median nerve test. Now, we all know the median nerve floss, and we're going to show it later on in the presentation. It's a tremendous exercise to help decrease sensitivity to the median nerve. However, this is a great test to show the patient what's wrong with them. And with doing this test, and if you hop on Chiro Up, you'll be able to go into the clinical evaluation section, type in on the 3 bars, median nerve test, and you're going to see with, unfortunately, his narration, but I get to demonstrate it, of how to do this test. And it's very simple, it's easy to use, and it's going to show the patient their dysfunction. When you perform this test appropriately and they get reproduction of symptoms in those first 3 fingers, you can now differentiate, is this coming from the wrist mostly, or coming from the shoulder? There's a lot of times where you move the elbow around and move the wrist around, there's no reproduction of symptoms, but then you start to actually stretch them now from the arm, or even with a little bit of shoulder depression with this test, and like, oh, that's it. That is what I'm feeling. And it provides you some confidence in knowing what's going on, but also the patient will have confidence and you know what you're doing to them.
That's a surprise too. That's a treat for your patients. One of the things that I often think about, that when I started in practice, I didn't use, there's your setup.
I was going to.
Yeah, I didn't use a lot of nerve tension tests in the upper extremity. In fact, there probably weren't a whole lot at that time, but we always used lower extremity nerve tension tests like a straight leg raise. If you think about a lumbar radicular complaint, or really any neurologic complaint in the lower extremity, you probably wouldn't want to skip a straight leg raise. But in the upper extremity, too often times I was skipping them. And so once I learned the upper extremity nerve tension test and then the subsequent flosses, it was a game changer. It was like learning the straight leg raise for the upper extremity. And fortunately, they're really simple. That this test here, you can go into Chiro Up and check out the video of it, but we can also run through a quick self-test of this, that if we have the patient and they have numbness and tingling in their fingers, we want to determine, is the median nerve irritated, or the radial nerve, or the ulnar nerve. We'll run them through a tension maneuver. So if we think about how would we tension the upper aspect of that nerve, the brachial plexus, that's simple. Contralaterally flex your head. And how would we tension the lower portion? That's simple. We do a Phelan's test. So when we combine those with arm and elbow extension, now we're getting a stretch of that whole nerve. And if they have increased numbness and tingling, the median nerve's involved. The good news, testing the radial nerve is super simple. It's almost the same. We're going to stretch the brachial plexus the same way, but we're going to move our hand into a Butler tip position on the backside to stretch the radial nerve. And finally, an ulnar nerve tension test is to make a circle, turn that into a monocle over your eye, and if you have numbness and tingling on the 1.5 digits of the small side of your hand, now we know the ulnar nerve could be involved. So using those tests on a regular basis can really help us differentiate which nerve and even which point in that nerve. And it'll be crucial to understand those tension tests to understand why those nerve release maneuvers have been proven to be so effective. A lot of the data that we'll cover here in a couple of minutes talks a whole lot about mechanosensitivity, and especially the adhesions that develop between the nerve and how to release those. This is how we test, is that appropriate?
So with your next patient, if you'd like to give something a try, go through the test for carpal tunnel syndrome. When you're all done with that test, put them into this position and see what happens. Sometimes they still won't get reproduction of symptoms, but if they're laying down, nothing else is active, and then you start to elevate or depress a shoulder, it may reproduce their symptoms. The cool part about that is, one, give a positive test and reproduce symptoms. The second part is you're like, see, Mrs. Smith, your wrist isn't moving at all. However, now we're getting reproduction of symptoms. There's something up in this area that may be causing a problem, and we're seeing the research just published this year, this month, I think it was, this month or last month, is a cervical manual therapy has a significant impact on carpal tunnel syndrome. So what we're finding is that these nerve sensitization maneuvers do 2 things. They influence us, and they also influence the patient behavior. So let's go into actually how to diagnose or how to evaluate carpal tunnel syndrome.
Yeah, one of the things that's interesting is this study that had come out last year that talks about the dermal findings associated with carpal tunnel. Again, if we think about, that's just dermal. If we think about carpal tunnel syndrome being not necessarily neurologic, but more of a vascular issue, we wouldn't be surprised that the peripheral vascular supply is impaired. And so when we see patients who have some scaling of their fingers, when we see horizontal lines in their nails, when we see growth lines that are stopping, when we see spoon nails and discoloration, those are signs that there's impaired peripheral vascular supply. And if it's impairing this, then guess what's next? And guess what comes after that? So it's not surprising that this whole chain follows along. So number one, we look at their fingers. We'll also look at their muscle strength. So if somebody has significant compression, Remember, the outside of those peripheral nerves are going to be primarily sensory. The inside of those nerves are going to carry the reflex and the motor. So if we have peripheral irritation or compression, we're going to see sensory symptoms. Once that gets a little bit more substantial, now we get into the deeper fibers where somebody's being choked and passing out and there's muscle loss. So we may see atrophy in that patient, but we'll first see signs of weakness in the loaf muscles. So we're testing those muscles by having the patient flex and extend their fingers and opposition of the thumb. We can also see, has this been there a long time? And those patients who start to have atrophy in their thumb, there's a lower likelihood that conservative care is going to be the solution for that patient. So hopefully we're catching them a little closer to the origin.
Yeah, when you sort of see atrophy really in any part of movement or visually, unfortunately that has been there for a long period of time. So we want to make sure that we keep that in mind with our prognosis, that may not come back. That doesn't mean we can't increase function, we just may not increase that muscle volume or strength. Keep in mind that when we work with any kind of upper extremity neuropathy, a lot of times, in fact 77% of these are double crush injuries. So looking at the neck, looking for any kind of cervical degenerative problems or disc problems that could be causing this, or maybe a different type of diagnosis. I know in my first couple of years in practice, I never made the diagnosis of thoracic outlet syndrome. I just didn't. It doesn't mean I didn't see any of those patients. That just means I didn't make any of those diagnoses. And unfortunately, that's unfortunate for those patients, but like you said with practice, it's this learning experience that as you start to string together these moments of seeing these patients, you can start to get a cue from that patient of what's going on. For example, in this next one, patient comes in, they have their hand like this, and this feels great. I never met a shoulder that felt really good with it above the shoulder or above the head. If we get that kind of presentation with an arm abduction sign, then we really want to look at more of a cervical radiculopathy as compared to a shoulder problem. The same with the arm squeeze test. If you haven't seen that test, take a look on Chiro Up. Great test to help differentiate. Am I working with a neck problem? Am I working with a shoulder problem? Or in this case, a neurologic problem?
Well, sure, those are probably two of the biggest concerns. Is it a cervical radiculopathy? Is it a TOS, or is it something happening downstream? And so I love this arm, the shoulder abduction maneuver. As you said, shoulders don't like that. TOS doesn't like that either. Another differentiator of TOS is that 9 out of 10 cases affect the ulnar nerve. So if we're dealing with symptoms in the median nerve distribution, we're probably not going to have a lot of TOS overlap in that case, but there may be some comorbidities where there's a double crush syndrome. The one thing that we really want to think about, though, downstream is that the pronator teres is the second most common cause of compression of the median nerve. So this study that looked at 174 extremities found that 12% of them have pronator teres syndrome. So a lot of our patients, 1 in 10 who have numbness and tingling in that median nerve distribution, isn't happening at the carpal tunnel, it's happening at the hand. And one of the reasons that explain that is the median nerve travels through the carpal tunnel, but that innervates the 3.5 digits. It doesn't innervate the palm. So when we see the palm is affected, it means it's more than just the carpal tunnel. The palm is innervated by the palmar branch of the median nerve, which comes outside the ligament and into the palm. So if we have palm involvement, we have to look upstream. And one of the places that we really want to look upstream is the pronator teres muscle. So remember, the pronator comes off the elbow, has the median nerve living underneath it, and the median nerve doesn't like compression.
Yeah, so one of the tests, and check out the condition reference section in Chiro for pronator teres syndrome, because this is one of those that sometimes you get lulled into, well, this is cervical radiculopathy or this is a carpal tunnel syndrome, and you're in the wrong spot. So fortunately, the tests are very simple on making this diagnosis. But getting back into the treatment of pronator teres syndrome, we covered here. Look, I've got the video. Who loaded all that up? They did a pretty good job of that. I forgot we put that in there. So I really, this is one of those that when working with the median nerve at the wrist, there's not a lot of space there. Really need to use a good amount of force as far as a practitioner. We want to force them into full abduction of the fingers, really spreading apart those lumbricals and really working at that thumb and finger to open up that space. Now, we can't forget about other possible compression sites above that, and just like I went ahead in one slide, the pronator teres. So the pronator teres want to take through full supination. Elbow really doesn't matter as much, but I think just by the nature of this stretch, you're sometimes going to get some elbow extension in this maneuver.
So remember where that pronator teres is coming off of the elbow, part of the lateral condyle, and coming down, the median nerve's living right underneath there. So with any nerve release, we're going to take that tissue from a shortened state into a lengthened state as we strip through that muscle. So as I'm stripping through that muscle, I'm releasing those potential adhesions. And again, the diagnosis is going to be putting some pressure on that if we choke that area for a few seconds and the numbness and tingling increases in the median nerve distribution, now we're pretty certain that releasing that might provide some benefit.
That kind of reminds me of working at the subscapularis. It's like, oh my God, I can feel my fingers. I'm like, oh, that's a good sign. Normally, if you feel a heartbeat under your finger, you're in the wrong spot. Just like anything else, whenever we have a diagnosis, and as long as there's no red flags, no trauma that we need to be concerned about, we always want to employ some kind of conservative management before surgical alternatives. Because what we know now is that if you have surgery on the carpal tunnel syndrome, carpal tunnel on one side, you're going to have it again if you don't change your activities. Because what we know is those repetitive positions, those repetitive movements that are causing the problem to begin with, yeah, you can release it now, but it's going to come back. So really, it's not about making the diagnosis. It's about looking upstream and finding those things that are probably causing it to begin with and solving those with things that the patient can do by themselves. One of those being, coming into your office. We really want to make sure that we teach the patient as much about their diagnosis so they know as much as we know. And one thing that we know from carpal tunnel syndrome is working on the neck. Any kind of manual therapy and nerve flossing maneuvers is shown in the research to help these patients. We think of nerves as these static structures, but they're not. They have to bend and go in between muscles and go around bones. So just as much as our muscles and ligaments need a little bit of love, so do our nerves. As a chiropractor, there's something else that we can do. We can mobilize and we can manipulate. And this was the article that I was talking about. However, just this year, we know that manual therapy helps double crush injuries. These aren't just a finger, hand numbness and tingling. The problem is arising from above.
Yeah, well, I love that study. Those two by Fernandez de la Peña. He published 2 studies that said not only are desensitization maneuvers, so nerve flossing, nerve stretching, equally effective to surgery, they're much more cost effective. And remember, the future of healthcare means we need better clinical outcomes, higher patient satisfaction, and a lower cost. We meet all 3 of those. It didn't require a knife. It was equally effective and a whole lot more cost effective. You and I are in a very good position for the future of healthcare, and the research is vetting that out. One of the things that we want to employ for these patients, as Dr. Peña's told us, is we want to make sure that we're flossing the entire nerve. So the median nerve floss is a useful maneuver. Now, the difference between a nerve tension test and a nerve floss is typically with the tension test, we stretch both ends. We're trying to create a straight leg raise and create an ischemic traction of that nerve. With a floss, we don't want to do that. One thing that happens when this nerve has been irritated is the nerve root is swollen and the entire nerve is swollen, meaning greater hydrostatic pressure, meaning greater ability for fluids to weep out of that nerve over time. Well, that sticky fluid that weeps out of the nerve becomes a spot weld. So now our spot weld is, our median nerve is spot welded at the carpal tunnel, at the pronator, at the arm, at the neck, on the TOS. So all of those spot welds are creating traction. That my median nerve and every peripheral nerve doesn't look anything like a cadaver nerve. It's not a shoestring or a piece of beef jerky. It's a bungee cord. In fact, my ulnar nerve needs to stretch 0.5 centimeter just when I flex my elbow. So if that bungee cord is not stretching and gliding through its canal, there's going to be an ischemic problem. Somebody's going to be tractioned. So with a median nerve floss, what we're going to do, in contrast to the median nerve tension test, is we're going to stretch one end and release the other. Imagine a shoestring in a straw, and we pour some weak Elmer's glue in there. That's the spot weld. In order to get that freed up, we wouldn't pull both ends. We'd pull one end and the other end and one end and the other end. So that's what a median nerve floss does. We're going to put stretch on one end and relaxation on the other. Then we're going to put stretch on one end and relaxation on the other, and going back and forth between those two. Patient looks at their hand and then watches their hand go back. True of the median nerve, the radial nerve, the ulnar nerve, or any nerve we're flossing. Now, as a more advanced state, we may move into a nerve tension test to stretch both ends once we've started to break up those adhesions, or to get better neurodynamics, I should say. But we're probably not going to start with a stretch of both ends beyond the initial test. So we'll perform the median nerve glide. We'll also stretch at the carpal tunnel itself. So the median nerve glide, this is one of your favorites, so I'll let you run through it here real quick.
We all have our favorites, and this is just not one that I utilize, and that does not mean there's not great research on it, and it's a very important stretch. It's the best exercise for a patient is the one they're willing to do. and obviously you want to do something productive, but most of our exercises are designed to get somebody moving, and that's what the nerve flossing and really all of our stretching does. Whenever there's one little hiccup, I didn't quite understand this, I didn't have a video for that, I didn't have a picture for that, you all know the result. The result is I just didn't do it. So I try to find, just like Dr. Burles, and really all of our exercises in Chiro, they're based on being simple, using less bands, less equipment. There's no excuse, meaning if you can't figure out how to do a cervical retraction at home, you can't really argue that I didn't have the right equipment or the right space. So the median nerve glide is by making a fist, going downward, coming back up, and then pulling here and going like this, right?
That's impressive.
I've done the presentation a couple times. It doesn't mean I like it anymore, but if you want a detailed version of that exercise, you can look at it. Now, one that I do use now, and whenever we get a suggestion from a subscriber, we go ahead and make that video. We turn it into pictures. We put it into Chiro Up. This is a great research article, and a subscriber gave us this exercise right here. As far as just putting your hand on the wall and pulling back your thumb, it does a great job of pulling those lumbricals and the thumb muscles to help pull and stretch that carpal tunnel, the median nerve. Great stretch, a lot of good research on it, and it's very easy. I like this one the most because whenever I have people do the nerve flossing exercise, they always forget about finger opposition and really abducting those fingers away from each other. So I'll see them kind of do this and maybe not even get any wrist extension. They're not doing anything. With these exercises, you really need those fingers spread apart and wrist extension, which you'll get with this manual carpal stretch.
So those two maneuvers that Dr. Steele just somewhat described, the median nerve glide as well as the manual carpal stretch, do have a lot of data to say that they work. And one of the funny aspects here is I tossed that median nerve glide your way because I realized I'm not sure exactly what are the 5 movements all put together. In spite of having taught the test, yeah, if somebody wants to track this and compare it to carpal tunnel, yeah, probably pretty close. But in reality, we don't have any super clinical ability to remember all of these things. And maybe the man of steel has more ability than I do, but I didn't remember how to do it. So I tossed it your way and you kind of did it the way that you would do it. In reality, I don't need to remember how to do this. I can give the patient an exercise program. They can watch the video at home of exactly how to do every nuance of every exercise and make sure that they are getting those best practices, whether I remember every aspect of that or not. And that's why I love automating that process through the Chiro Up system. One thing that we do know is that when we incorporate those maneuvers, when we don't forget to tell the patient those things, they get better. That this randomized controlled clinical trial said that using neurodynamic techniques provides significant benefit equal to surgery in most cases.
And neurodynamic techniques are nothing that we created. I would highly recommend looking at Butler's book, looking at Michael Shacklock's book, Clinical Neurodynamics, and getting the full scope of those books. We have the synopsis in Chiro Up and the videos and the explanations, but a lot of times you want to hear from the horse's mouth and you really want to go in and dive in, take a look at those books. Those guys are experts and phenomenal at what they do. However, if you want the quick version to test out in your office, because we're not asking you to change everything you do in your office, but try some new things. It really helps get you out of the grind of the day-to-day. I know when I'm in my 8x10 room and seeing patients all day, sometimes my mind does wander a little bit. So it's really good to refocus and to maybe spice it up a little bit with a new way of manipulating, a new way of doing some exercises. I know with this one, the carpal tunnel syndrome is a fairly easy one to treat. You have some good success or really no success is what I found in my experience. I'm going to start off with the neck. So I'm going to work on stretching out the scalenes. A lot of times you're going to see this in the anterior middle scalene as far as your irritation of these nerves, where the nerves go through the muscles, but also the unilateral pec stretch works well. I will say that carpal tunnel syndrome is normally on the dominant arm, so technically you should be just doing the dominant arm. However, I do the corner pec stretch. I don't know what you do as far as in practice, but I changed my Chiro protocol to always have that corner pec stretch because what I know is cervical degeneration and cervical problems is almost always due to that upper cross syndrome posture. So why not stretch out both sides? While they're not having the problem on both sides, we can definitely make a dent in correcting that posture with that exercise.
Certainly, and we also want to stretch out the wrist flexors. We know that any site of compression, whether it be with the pronator muscle or one of the other wrist flexors, if it's starting to cause some compression of the median nerve, there's going to be an enhancement of symptoms. So we have that patient do a wrist flexor stretch, having them come down. And I like contract, relax stretches for all of these, where we take the muscle into a stretch state and then have them contract against the resistance.
So we've done the square wrist side. That's it? That's all you have? Look at this.
Square wrist?
Man, you've been...
Is it square?
No, it's just that you don't have any flexibility there.
Well, see, I see patients do this. So patients are these things that come in and they'll complain of something, and then you fix them.
Yeah.
So the wrist flexor stretch, taking that down as far as you humanly can, push against the resistance and then stretch back. That can be done just to broke a little, so it's the lights. These LEDs are hot. And so having that patient do it either against the wall or even on the floor, on all fours, to stretch that out for baseball players, athletes who are using their hands a whole lot. That's a good way to stretch out before the game. We also know that ancillary types of techniques like acupuncture, putting in needles to the area, can enhance the blood flow, enhance the treatment effect. In this study said that acupuncture is superior to ibuprofen. I know you've got a crack coming here. I'm just wondering what it is.
No, it's not crack. We're talking about acupuncture. Oh, what are you searching for? One thing I want to mention about acupuncture is beginning in practice, I was like, acupuncture doesn't work. We now have another provider in our office that does dry needling, not acupuncture. I realize there's a difference. However, here's what I'm going to say, is that if you don't do that treatment, whether it's nutrition, which we don't do nutrition, but we have someone in our area who does. If you don't do dry needling or acupuncture, that doesn't mean it doesn't work. It doesn't mean you don't do it. Find someone in your area that does that. It's tremendous as far as the community feel when you start to refer to other chiropractors in your area for what's in their lane and what they're great at. Like extracorporeal shockwave therapy, in this case, ultrasound. Ultrasound is something that a lot of chiropractors used to use, and we don't do it anymore. So that doesn't mean that just because you have the machine, you have to keep on doing it. It's to recognize that what you knew then isn't necessarily what we know now. So being humble enough to understand what you're good at and what you're not good at, or what you've already purchased, but maybe just a waste of that patient's time.
And save it for other conditions, but not carpal tunnel. One thing that seems a little similar to ultrasound, but it isn't, would be shockwave therapy. So these are coming onto the market. A shockwave therapy device, you can either have a focused one or a radial one. They're fairly expensive. They're probably going to be about $10,000 for a radial shockwave therapy machine. The focused are even more expensive. They've shown a lot of promise because, as we've talked about a few times during this presentation, much of what you and I treat is blood flow related. So whether it be an arthritic joint, a stiff muscle, a neuropathy, a tendinopathy, it's a lack of blood supply. So our treatments for these conditions, especially the tendinopathy types of conditions, have transitioned from trying to suppress blood flow with NSAIDs and ice and ultrasound to generating blood flow with dry needling and shockwave therapy. So shockwave therapy is something that started out as lithotripsy to blow up kidney stones, moved into other markets, and it's found a home in tendinopathies. It also has some benefit for neuropathies. So the shockwave drives a shockwave. It's a little ball that fits into a tube that bounces back and forth very rapidly, drives a shockwave into loudly and rapidly, and drives a shockwave into the tissue to enhance blood supply. The good news is it's quick. It's usually only about 2 minutes to get through enough cycles in order for it to be effective. The bad news is that's not always reimbursable. So you've got an expensive machine that may or may not be reimbursable. And we had one of these in our office.
And it worked well. So I have nothing negative to say about it. It was just loud, and we found there are other therapies that worked well for us that maybe we were better suited to use. I do want to bring up that Bridget brought up a question about PowerPoints being available. We will be sending those PowerPoints out after this webinar. So yes, you'll have all the pieces of information. I don't think there'll be a recording associated with that, but you probably don't want to hear Dr. Berlesman talk again anyway. So as far as home advice, which I got to be honest with you, I really believe that just as important are the things that you do to a patient in office, in the rehab. Really, with this kind of a diagnosis, we have to get it loose. We have to teach the patient to keep it loose, and then we have to give it time to heal. So when it comes to carpal tunnel syndrome, we just showed you the kind of things that get it loose. However, now we have to convince the patient to keep it loose, which are the exercises. And as far as prognosis, this is the number one thing you're going to hear in your office. How long is this going to take? I don't know. I honestly don't. However, here's what I know. They would take away compression. You can use a nighttime splint. You can take some anti-inflammatories. You can stop sleeping with your wrist like this. Those are things that are going to take away that compression irritation, and now you can give it time to heal. Most nerves, what I tell my patients, take a little bit longer than muscles and ligaments, but 2 to 3 weeks, I find that that patient's in that 75 to 100% range. depending on how long they've had it. If they've had it for 3 years, that prognosis is going to dramatically change.
Yeah, and a diabetic who has a bad career. And
Sure.
lots of factors that go into that. We also want to make sure that they're not doing something at home that causes compression or traction. So if their wrist is on the edge of a desk, if they're constantly stretching it at nighttime because of their sleep posture, those are things that don't work. And posture is a big one. That there was a study that looked at the intraneural blood supply. And when we take our wrist out of a neutral position, it does impact our neurologic symptoms. So one of the things that has been shown to work for this is a wrist splint. That a nighttime wrist splint is something that holds the patient's arm in a neutral position and allows us to get the results that we're looking for. So one of the things that I wanted to cover real quickly is we've gone through all the carpal tunnel components of this, but I'd like to show you where you can access all of this information. So if you'll, we've got a lot of subscribers on board here on the call. If you go into chiroup.com, what we're going to do is I'm going to give you a preview of the new site that's coming out in the next several weeks. So that site, it looks somewhat like the old one, but it's faster, it's better, and it's got some cool stuff. It has all the old stuff that if you want to go back and you want to review what we should be doing for carpal tunnel, you can still go into the condition reference. In the condition reference, it's going to pull up a list of all the conditions. You can open up any one of those. If you scroll down to carpal tunnel syndrome, you can pull that up. You'll be able to see what's the most sensitive specific orthopedic test. So here's where you're going to go after the webinar to say, I'd like to review that median nerve tension test. I'd like to review Phelan sign. I'd like to review manual carpal compression. If you need to review that last one, then you probably need to skip out now. But you can review any of those tests in there. You can also open up the description of the problem. So we keep this up to date. We've got a team of 3 doctors who goes through the literature. We mine out the best practice resources. And if you scroll down to the bottom, you'll see that there's a whole bunch of references, over 120 for carpal tunnel syndrome, that tell us what's the most appropriate way to manage this condition. So that gives you access to that. If you're not a subscriber, here's what I'm going to do just off the cuff. If you email Becky at chiroup.com, BECKI at chiroup.com, she's going to give you access to this in case you want to see any of those things. And we'll provide that link for you as well. So the new version has all of those things. It has all the orthopedic tests. It has the activities of daily living, the things that all the subscribers are familiar with. It also still has the ability to prescribe one of those. So if we go up to search for a patient, you'll see the search has changed just a little bit. We can bring up a patient. And once we bring up the patient, we're able to go over to the right side of the screen and create a condition report. And so this is where you create your condition reports to educate your patient about their diagnosis. So we pull up a region of hand and wrist, we pull up the diagnosis of carpal tunnel syndrome, and now your report of findings automatically populates. You're still able to modify any of those a little easier than before even. You can change anything around. You can create an MD letter, or you can print and send that letter. So now your patient receives a report that says, here's what's wrong, here's what we're going to do to solve that problem, here are the things that you need to do. I still remember when I started in practice, I had a patient on his 3rd visit. He said, you know what, I finally feel a little bit better. And I thought, oh, good, my treatment is working. He said, my neighbor told me to quit sitting on my wallet. And I thought, why didn't I tell you to quit sitting on your wallet? So unfortunately, we get busy in practice. We don't remember all of those things, and sometimes they go by the wayside. Chiroup doesn't forget any of those things. Sometimes it doesn't populate the page that they're supposed to be on the new version that's still in development, but they're all in the report. So having access to that is essential. You'll still be able to create the MD initial reports. You'll be able to create the Google review, so your patient gets a survey 30 days after saying how much better are you, how many times were you seen, how likely are you to refer, so you can see your stats by diagnosis. But one thing that we are super excited about in version 3 is this, not me being gone, but this, being able to send that patient when they come in, when they first call into your office and give you their information, and you schedule a visit, you can send them a survey that asks them their entire history. So the patient can provide their OPP-QRST for you before they ever run into the clinic. How much time is that going to save in my office and in your office? Well, I spend somewhere between 10 and 20 minutes collecting the history from the patient. I'm going to review that history with the patient in about 2 or 3 minutes. I've got the alerts that this patient had recent trauma and they're taking Coumadin. Those are things I want to know right off the bat. I've got a diagram of their picture. A picture of their pain. I've got the OPP-QRST, the accident details, their VAS, their Oswestry, neck disability index. I've got their review of systems, their lifestyle history. and it's done for me, and it only took the patient about 5 minutes. If you can't tell, we're a little bit excited about this. We hope that you'll be excited about it. And that's coming at you as a subscriber at no additional cost. The same subscription that you have now gets you this. So we are super excited about that one.
You know, our goal is to elevate and unite the evidence-based chiropractic profession. We're going to do that. We're going to do it through creating some standards. And it's with offices like you that we're able to do that. And we can now take this information, we can turn it into research and help support where we're going in the future. The perception that chiropractic is never going to see greater growth in the next couple of years from the work that we're doing. We're just honored for you guys to be a part of what we're doing. And if you have any suggestions, any thoughts, let us know. We've got Brandon at Chiropractic, we've got Tim at Chiropractic. If you need an actual answer, go ahead and shoot me one. If you're just looking for a funny dad joke, Dr. Burrows will be happy to supply those. But thanks for joining the seminar. One thing you will get at the end of this seminar is you get a follow-up email. It's going to have all of the PowerPoints. So in case you want to go back to PowerPoints, but PowerPoints are not the way of learning in the future. The way we're going to learn in the future is through knowledge transfer systems. And it's by finding services or people who have the answers you're looking for. I hope you consider using Chiropractic in the future to look for those answers.
And those of you who are using it now, which is the majority of our audience out there, watch for the link for the V3 intro webinar. So on August 17th, we'll be hosting another webinar. We're going to go through version 3. So some of the preview that you saw, but greater detail with all of those features, as well as some other benefits that our coders are wrapping up right now. It's not out to the public at this point. It's being used by some beta users. It's being used in our clinic now for the past couple of weeks. We're working out the last polishing details on that. It's going to be awesome. So we hope to see you on that webinar on August 17th. You can register in the link that follows. Thanks for joining us today.
Thank you.